Good afternoon, everyone. First of all, thank you for this opportunity. So, Dr. Ajay has covered the targeted therapy part. I will be discussing the role of immunotherapy or recent advances in immunotherapy. So, first of all, as we know, lung cancer is one of the deadliest cancer, which is affecting almost one third of the population who has cancer. Uh, to understand, basically, lung cancer is divided into small cell lung cancer and non-small cell lung cancer. Non-small cell lung cancer accounts for 85% of the cases, whereas small cell lung cancer accounts for 15% of the patient. Again, non-small cell is divided into adenocarcinoma, squamous cell carcinoma, and large cell carcinomas. And further, there are various subtypes which are very less common. So, how immunotherapy works? Basically, chemotherapy works by cytotoxic effect. It kills the cell either through acting through cell membrane or at the level of nucleus. How immunotherapy acts through activation of immune system. So, whenever there is a presence of cancer cell in a body, it is first immune system in the priming phase will present T cells. T cells are the immune cells which will attack the tumor cell. How tumor cells grow? They evade the attack by T cells. So our immunotherapy helps in activation of T cell, which will kill the cancer cell and help in curing the cancer. So there are these receptors PD-L1 and CTLA4. These are the inhibitors of this T cell activation. By blocking them, either PD1 or PD-L1 ligand or CTLA4, we will activate the T cell and it will help in cancer control. So, briefly, these are the immune checkpoint inhibitors which are most commonly used in all solid tumors and few of the hematological tumors. I will tell about doses. Like anti-CTLA4 inhibitor, it is ipilimumab. The common dose is 3 milligram per kg given 3 weekly or 10 milligram per kg given 3 weekly. It has a role in lung cancer, melanoma, advanced renal cell carcinoma. Nivolumab, it's anti-PD-1 inhibitor. The dose is either 3 milligram per kg or 250 milligram every 2 weekly. It is indicated in melanoma, non-small cell lung cancer, renal cell cancer, and many of the solid tumors. Other PD-1 inhibitor is pembrolizumab. The dose is 200 milligram every 3 weekly or 400 milligram every 6 weekly. It is almost now approved in almost most of the solid tumors, including melanoma, non-small lung cancer, head and neck cancer, Hodgkin's lymphoma, urothelial carcinoma. Another PD-1 inhibitor is semiplimab, which is at present not available in India. The dosing is 350 milligram every 3 weekly. Other agents are PD-L1 inhibitor, that is PD ligand inhibitor, that includes atezolizumab, avelumab, and durvalumab. Atezolizumab and durvalumab both are useful in non-small cell as well as small cell lung cancer. The doses commonly used are 840 milligram every 2 weekly or 1200 every 3 weekly. For durvalumab, dosing is either 10 milligram per kg every 2 weekly or 15 milligram 1500 milligram every 4 weekly, that depending on the indication in therapy. Brief side effects with immunotherapy. Immunotherapy has immune mediated side effects which may affect any part of the body, including starting from CNS to the bone, lungs, liver, brain, heart, as well as kidney. Here we can see it may cause uveitis or Sjogren's syndrome in eyes. It may cause interstitial lung disease or pneumonitis in lung. It may affect hepatitis. The common side effects like skin rash, pruritus, psoriasis may happen with immunotherapy. It may cause joint pain. It may cause encephalitis. So, and also few of the times it may cause myelosuppression. The common thing about immunotherapy, it has a less adverse effect compared to chemotherapy. It may cause serious side effects, but the number of patients getting affected by serious side effects are less. So these are few typical features where the side effects appear, like Rash is the earliest side effect which we can see within 3 to 4 weeks, diarrhea being the second common, while the other toxicities will appear later in the course of immunotherapy administration. So basically, now moving to lung cancer, where basically immunotherapy is used. It is used in stage 4 lung cancer in the first line setting, in both non-squamous as well as squamous cell carcinoma, or in the second line setting. It has got role in the curative setting also, in stage 3 unresectable uh, lung cancer, and as well as metastatic extensive stage small cell lung cancer. So I will be discussing this. So how we make the decisions? Dr. Ajay has nicely told. Still, we consider performance status of the patient, what is the disease status, what is the histology, and the most important thing while using immunotherapy is PD-L1 expression level, and other is tumor mutation burden. This PD-L1 is tested by immunohistochemistry. There are two scores, total proportion score and combined proportion score, which are used to help and guide in use of immunotherapy for particular indication. Other factors which affect the use of immunotherapy are what is our goal, overall health of the patient, and any history of autoimmune disorders like rheumatoid arthritis, other arthritis, and some interstitial lung disease. So we have to be careful while starting immunotherapy if patient has some history of immunological disorders. So in the first line treatment, I have summarized how we can use it. When we will be doing a PD-L1 status in patients who have PD-L1 status more than 50%, we can definitely use only immunotherapy as a treatment of choice. This is for the patients who have there are no molecular targets positive. So if molecular targets are negative and patient's PD-L1 is more than 50%, we can use immunotherapy alone. Other options, as we can see, there are 8 to 9 treatment options. If the disease burden is high, we can use immunotherapy pembrolizumab along with pemetrexed platinum compound. We can use atezolizumab along with platinum and taxane, nab-paclitaxel. Also, we can use a combination of nivolumab plus ipilimumab in the first line setting. Second second classification is the patients who have PD-L1 score of 1 to 49. The common practice is to use immunotherapy along with chemotherapy. As I have told, it can be used with pemetrexed plus platinum as well as paclitaxel and carboplatinum, where we use atezolizumab. In patients who have PD-L1 less than 1%, there also immunotherapy has shown promising benefit, and it is recommended to use along with chemotherapy. The agents used will be pembrolizumab or atezolizumab. So this was for non-squamous cell lung cancer like adenocarcinoma. So this is again a repetition of the same, where the combinations have been displayed, like pembrolizumab along with pem-carbo, atezolizumab along with paclitaxel, and one VEGF inhibitor bevacizumab. Other option is atez plus nab-pacli and carboplatin, which we will be using. So in squamous cell carcinoma, the recommendations are more or almost same, where in patients with PD-L1 more than 50%, single agent immunotherapy will be treatment of choice. Also, we can use immunotherapy along with paclitaxel, paclitaxel or nab-paclitaxel. Another agent, cemiplimab, which is not available, that also can be used. Same for PD-L1 less than 1%, we use pembrolizumab along with chemotherapy, and for patients with PD-L1 between 1 to 49%, pembrolizumab along with chemotherapy. So subsequent line, when patient has progressed on chemotherapy and we have not given patient immunotherapy in the first line, we can use the immunotherapy in the second line. The options are pembrolizumab, atezolizumab, based on different trials. Other role in the curative treatment of lung cancer in stage 3 unresectable lung cancer, durvalumab is the immunotherapy which is FDA approved. Stage 3 lung cancer which are treated with concurrent chemoradiotherapy. After completion of a chemoradiotherapy, if the patient has not progressed, we can give durvalumab maintenance therapy for 1 year, where we use 2 weekly doses, and it has shown promising benefit in the form of improvement in survival and progression-free survival. Next use is small cell lung cancer. In small cell lung cancer, we have two agents which we can use. One is durvalumab, other is atezolizumab. Here we combine immunotherapy along with the recommended chemotherapy of etoposide along with platinum, which is given. If we combine it with carboplatin and etoposide, we give it for 4 cycle, and if there is a response, we will continue as a maintenance therapy. Same for durvalumab, we can combine it along with chemotherapy. We will give it for 4 to 6 cycles, and if there is a response, we will continue it for as a maintenance therapy. Immunotherapy addition to chemotherapy has shown improvement in overall survival in this subset of patients. So we may be having promising results with immunotherapy. At present, we are restricted by the cost of immunotherapy, which that is why only few percent of the patient, maybe we can see 5 to 10% of patients are affordable for immunotherapy. So in future we can see promising results with this. Thank you. Thank you.
Thank you, Dr. Sunil. Any questions?
Any questions are welcome.
Dr. Sunil, when we see that there are patients who are on durvalumab and many other immunotherapy drugs, there is this form which comes along with the patient for sanction of the, I believe, for the grant for the therapy or something. So can you just tell us about the procedure?
Yeah, so that is a NRC sanction form. These all the drugs are almost costing, like pembrolizumab, atezolizumab, it costs 4 lakhs, nivolumab cost 2 lakhs. So these drugs are not directly given by the authorities, like those who are central government employees through CGHS or through BRC. They will not provide such a costly drug at so easily. So we will provide the details to the authority that this is indicated. We will give the evidence, the trials which we have discussed, or we have the details which will provide that this was the overall survival benefit or this was the benefit. Based on that, their board will discuss whether this is really indicated. So most of the time, like it is not rejected.
Not very difficult
and
to get
yeah, but the thing is, it involves some administrative things. The form has to be sanctioned by our medical superintendent, and then it goes to their authority. So it takes 3-4 days, but it is necessary.
And are the patients being registered for any clinical trials, that ongoing clinical trials, and they are being provided with these drugs?
So at present, recently we have started durvalumab trial. So we are recruiting the patients for same.
Thank you, doctor.
Thank you.
We also know that in the dispensary also durvalumab is not readily available. Whenever there is a patient who is coming for this therapy, we have to inform the dispensary so that the dispensary arranges for that drug. So in advance it has been to be sanctioned, to be arranged, and only then the patient gets admitted for therapy. Thank you, Dr. Sunil.
So after giving immunotherapy, if patient gets lung mets, then what is the line of treatment?
So basically, immunotherapy at present has a role maximum in metastatic setting where the patients have metastasis. So if patients after receiving immunotherapy develops new lung metastasis, then we have to change treatment line and we have to move to the subsequent line of chemotherapy.
And for palliative patients also we can give?
Yes, yes. Main use is in palliative setting. In curative setting, there are certain indications, as I told, like stage 3 lung cancer. Up to what time we should give it? So basically, first we give 4 to 6 cycles, then we see a response. If response is there, we have to continue it as a Maintenance therapy, the duration tried in trials is 2 years in metastatic setting. So for, we tell patient that for up to maximum 2 years, they will have to take it.
Any more questions? This is not related to targeted therapy or immunotherapy, but I just wanted to ask, like in the wards when we get patient with stage 2 lung cancer, there are some patients who have been referred to palliative medicine for early palliative care. So what is, I
No,
mean,
maybe
how do
s-
you classify that?
Maybe though those patients may not be stage 2, either stage 3
Stage 2 or
advanced
stage 3
or
advanced?
stage 4 advanced disease.
Stage
In
3.
stage 3, there are certain situations where surgeons will not be able to operate the tumor, or the tumor will not be included in the radiation treatment field. So at such times, we try giving chemotherapy and reducing the tumor size, then trying radiation or surgery. Or if tumor still doesn't respond, we make it, we treat it as a palliative intent.
Thank you, Dr. Sunil.
Thank you.